Here on GameChangers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count. Hey CEimpact subscribers, welcome to the GameChangers Clinical Update Podcast. I'm your host, Rachel Maynard, and today we'll be discussing the critical issue of shared clinical decision-making for immunizations, a topic that affects patients and pharmacy teams across the country on a daily basis. This is coming up even more often now because earlier this year, the Centers for Disease Control and Prevention, or CDC, made a number of revisions to the pediatric immunization schedule, including that shared clinical decision-making would now be used for certain pediatric vaccines that were previously routinely recommended for all children, including influenza, COVID-19, and several others. But these changes have raised a lot of questions and confusion from patients, parents, and pharmacy teams. So I'm very excited to have an expert in this area, Dr. Elizabeth Skoy, to help us walk through practical advice for managing this confusion and addressing common questions. So welcome, Elizabeth. So happy to have you.
Well, thanks for having me. I'm happy to be here.
Excellent. And I know you've done a number of podcasts with us before, and so listeners may be familiar with you, but for those who aren't, could you just share a little bit about your background, your current role, and why you're interested in this topic?
Yeah, so I'm a faculty professor at the School of Pharmacy at North Dakota State University. I'm also a community pharmacist currently, and that's always been my practice area. Really have done a lot of work in the area of vaccination, training pharmacists and pharmacy technicians and preparing them to provide vaccines, as well as just kind of becoming an expert in that space of vaccine hesitancy and healthcare recommendations and things like that. More recently, until the ACIP was overturned with the new administration, I was a member of the ACIP work group for adult RSV vaccine. I was the appointee from the American Pharmacists Association to stand on that working group. And so I worked on that work group for adult RSV vaccine for a few years. And so got a really wonderful experience and kind of that in-depth behind the scenes look at how vaccine decisions used to be made in our country. And so just kind of have a lot vested in a lot of interest and research area in this particular topic. So I always like to talk about things like this.
Excellent. Well, we are so happy to have your practical expertise and also your expertise on the sort of back end side of things and knowing how operations were. So yeah, that's great perspective to bring to this discussion. And I think, to start things out, one of the most important things that we just need to get on the same page with is what is shared clinical decision making? What does it mean in the context of vaccinations? And just describing where that definition comes from and what we need to think about in terms of the context there.
Yeah, so the topic of shared clinical decision making isn't necessarily new to vaccination. We've had that as a recommendation from the ACIP previously, before more recently with the recommendations for a broader application of shared clinical decision making. But shared clinical decision making is really having I always like to say there's two experts in the room. And they both have equal power. And so when we talk sometimes about, in the scope of healthcare, a lot of times the healthcare professional, whether it's the pharmacist or a medical doctor, might be have a higher level of expertise in that room. And so they're the ones that are making a recommendation to a patient. The patient is expected to accept that recommendation. If they don't accept that recommendation, then sometimes we go through processes of like medical, motivational interviewing to get them to accept the recommendation that we have. This is a little bit of a different approach in the fact that when you are doing true shared clinical decision making, there's two experts in the room at equal power. The patient is the expert in their life and their circumstances and their values and goals. And then the pharmacist or the other provider is the expert in the healthcare part of things. And so there have been times that shared clinical decision making and that recommendation have been previously applied to vaccination. And some of those have been like historically the HPV vaccine for individuals 27 through 45. the hepatitis B vaccine for individuals 60 plus with diabetes, or just a couple of recommendations. But then, as you kind of previously mentioned, some newer recommendations from the CDC have put a broader context as to how that's going to be applied to
Mhm.
vaccines.
So that's a great overview, and I think one thing that you highlighted is that pharmacists are one of these healthcare providers that can be involved in the shared clinical decision making. It could be any, the healthcare provider in general, but pharmacists are one of those healthcare providers, the medication experts that have that expertise, and they can be one of the medical expert with the patient expert coming to that discussion. Is that right?
A
Just to
hundred
clarify
percent.
that.
Yeah. And
Mhm.
so, and that we're, explicitly mentioned in the CDC's definition of shared clinical decision making. So of individuals or healthcare professionals that can participate in shared clinical decision making, pharmacists are specifically mentioned in there as one of those that can do that and should be doing that. Um, another just kind of a note too, as we're talking about this, that the term shared decision making gets a little confusing, but the term shared decision making has really been around for a number of years, and almost 20 years. It's been kind of utilized in the literature and as an application to care. Historically speaking, I think the area that is probably the most documented would be in oncology, where there's different treatment options, and you are working with the patient to kind of figure out what their goals are, what's important to them, and quality of life versus,
Sure,
morbidity versus mortality, that type of a
sure.
thing, and then you're coming together to make a decision. When shared clinical decision making came and was used as from the ACIP as one of the recommendations, which kind of inserted the word clinical, or C, the word C in there,
Mhm.
um, as a way to do that. And so when they created that definition as one of the three options for vaccine recommendation, pharmacists were specifically mentioned it there. So just to really, like you said, really highlight that, especially since this
Mhm.
is our audience as pharmacists today, that yes, you are just as equal as everyone else, the medical doctors, nurse practitioners that are going to be providing that service to patients.
Absolutely. And super important that they highlighted that too, because pharmacists are one of the main providers of immunizations in the US. And
Mhm.
so recognizing, I remember when that term was first sort of coming out, and there was a lot of confusion around, do we qualify? And the answer is yes. So just to make that clear, I think that's great. So what sort of prompted this topic was the change in pediatric recommendations from CDC. And as I mentioned, a lot of the recommendations that were routinely recommended for pediatric patients in the past are now uh, under this shared clinical decision-making sort of model. And so maybe you could actually clarify that too. What is the difference between what does that mean between now that we have, say, influenza COVID used to be routine, now there's shared clinical decision making? What is the difference? That means that patients and clinicians now have to have this conversation before the vaccine is given, or what exactly does that mean, and how does it compare to what they were before?
Yeah, so I think maybe to take just one step back, and for the audience that's listening right now, you might already be aware of this, but it's really interesting to me how many individuals, patients, as definitely patients as well as healthcare professionals, even just look at the CDC schedule every year, get the updates, and then they're like, "Oh, good to go. Okay, now that's the new update," and they move on without kind of having that more behind the scenes aspect of things. And
Mm,
so since I was on the ACIP work group for RSV vaccine, I was able to really see and live, how the CDC had previously made recommendations, and that was utilizing a framework called evidence to recommendation. There was
okay.
very specific questions. I'm not going to go through it all right now, just probably for time for the podcast. And it's probably something that would be better to be read or reviewed. But looking at very in-depth evidence for a number of questions as to like the morbidity and mortality of a disease in a certain group and population, as to like the effectiveness of the vaccine, the side effects of that vaccine, and really making a very strong evidence-based recommendation to have that appear on the schedule. And um, and especially with newer vaccines, and we probably can remember this with the adult RSV vaccine, sometimes that evidence changes. So when the
Hmm.
adult RSV vaccine came out, you guys can probably remember there was shared clinical decision making attached to that vaccine. And then it came to a regular recommendation. There's three recommendations typically that have historically been provided by the ACIP. The first is the evidence. A first recommendation is just like a blanket recommendation, meaning in a certain age group or a certain patient population, everyone should get vaccinated. The second would be a catch-up, individuals who haven't been vaccinated, or if there's a better, newer vaccine out, how to get them that vaccine recommendation. And then the third is the shared clinical decision-making. And historically speaking, that shared clinical decision-making has been made when the evidence to recommendation just isn't strong enough to do a blanket
Hmm.
um,
Routine.
vaccine
Yeah. Yeah.
recommendation to an age
Hmm.
group. So
Hmm.
example, I think that probably pharmacists are the most familiar with, probably, for widely speaking, might be the HPV vaccine for that 27 to 45 years old, or potentially the or I'm sorry, the hepatitis B vaccine for
Hmm.
60 plus diabetics.
Hmm.
When we're looking at those recommendations, it means that we don't want to exclude them from the opportunity to get vaccinated because there's some people that will very greatly benefit from this vaccine, but the evidence is not strong enough to um to vaccinate an entire group or population. Okay,
Hmm.
so
Hmm.
I would like to put that in our in a bucket in our brain right now. So that's the historical context, right?
Hmm.
So
Hmm.
evidence to recommendation the evidence has not been there to show that you should vaccinate an entire group or population.
Hmm. Hmm.
So when these newer recommendations have come out, the CDC with the new ACIP structure from the CDC director and the Secretary of HHS for the U.S., Secretary Kennedy, they, as you probably all the listeners know, have they replaced the ACIP and then they ended up kind of going away from the evidence to recommendation framework. So when these newer recommendations came out for influenza, for pediatric, for, oh, well, shared clinical decision making, COVID-19, when we're going through those, there wasn't an evidence to recommendation framework. There wasn't that evidence. There wasn't well, why? Why is that? What's the evidence behind that? Whereas historically speaking, you can look at the evidence to recommendation framework for those other previously recommended vaccines, and you know exactly why. So if I'm having a conversation with a patient who's, hasn't been vaccinated with the HPV vaccine and they're, 30 years old and they've been married for, the last, 12 years of their life and they, have had, normal cervical cancer screenings and they've had very few previous sexual partners, might not qualify that
Hmm.
like shared clinical decision making
Hmm.
between me and that patient. It would be surprising to me if when we talk together that we would get to vaccination. We
Sure.
might, she
Yep.
might say, well, I might get divorced in a few years, or
Yep.
who
Yep.
knows
Yep.
what that might be.
Yep.
And so, but this isn't the case. We don't have that. And so that's kind of where this has put us in a really unique situation that this recommendation is there. And so how we really apply that into practice is kind of a little bit yet to be determined.
Okay.
Hmm.
Okay, that's good perspective. Good to hear that clarification, because as you said, part of that discussion is around benefits, risks, assessing individualized preferences, and how that all ties in with the patient. So that does make it challenging. So I guess to sort of provide context too, we still do have American Academy of Pediatrics, AAP recommendations for pediatric vaccinations as well. And maybe you can just speak to what those look like and how they compare to the updated CDC recommendations. Any key things for us to be aware of there?
Yeah, so the AEP schedule, which has really been endorsed by most medical groups as well as the American Pharmacists Association, that schedule is the previous schedule, right? It's the schedule we had, a year ago.
Hmm.
For
Hmm.
like, for instance, influenza, everyone for 6 months and older.
Hmm.
And so it kind of puts, I think for the first time in a long time, although there's been some disagreements maybe between some medical groups and the CDC
Hmm.
in the past. But for the most part, the schedule has been endorsed and come to terms with, or maybe like slight, slight statements made from groups. But this is kind of the first time that I've been around where a whole new schedule has been approved from various organizations. So I think as pharmacists to know that that's happening, right? To know that
Hmm.
maybe medical providers, pharmacists might want to be considering to follow that American, Academy of Pediatrics schedule and knowing why that is, and I think that background where I would just said that, we don't have the evidence as to why all of a sudden we wouldn't blanket,
Hmm. Hmm.
vaccinate every child 6 months
Hmm.
and older with
Hmm.
influenza vaccine.
Hmm.
We don't have the evidence to that. Personally, if there's evidence for why not, I would love to see that. I'd love to see an ETR framework of that. And then that kind of changes the game if you have experts
Hmm.
looking at that and saying, oh, wow, okay.
Hmm.
But we don't really have that. And so I
Hmm.
think that's, without talking with every member of those organizations that made those decisions, you can kind of imply that that's kind of where we are and why we're there right now as to why so many groups are looking at that schedule. So I think for our listeners with the podcast that, what that means for you as a pharmacist is that that might be a difference in, for instance, if you have a standing order or a state protocol
Yeah,
that
I was
only
gonna ask about
allows
that.
you to
Yeah,
follow the CDC's schedule, right?
right,
You have to know that your state or
right.
what is allowing you and binding you to vaccinate in your state is going off of, a CDC schedule. But you also have to know that if you have like a more of a, collaborative practice agreement, that medical
Sure.
professional who might sign off on that collaborative practice agreement for 6 and older has the backing of the medical community to make that decision as
Sure.
well. So, just depending upon how you vaccinate under what laws and legality within your own state and how you're prescribing vaccinations within your state.
Hmm.
So know that. Now, also, the CDC has said that all vaccine coverage will not go interrupted, at least in through December. And so, meaning that there's not going to be a denial for someone to get a vaccine.
Hmm.
A child, like for instance, a child, if they're 2 years old and get an influenza vaccine, there shouldn't be a denial from that. From the
Hmm.
CDC has said
Okay.
that.
Okay.
What happens after that, we don't know. Also, we don't know if certain provider or certain insurance companies might require some sort of additional documentation and attestation, maybe um, that shared decision making has taken place. That's really going to be dependent upon the third party. But
Hmm.
at least what we saw with some of the changes in recommendation from COVID vaccine this last year, most insurance companies were still paying for that without hesitation. At least from my personal experience, what I saw was just probably because they realized that vaccinating is going to be a lot less expensive for them
Hmm.
as
Right.
a payer than
Right.
having to hospitalize somebody with COVID-19, for instance, or any other
Right.
infectious diseases, or so. Um, it's kind of where we're at. I wish I had answers. I wish I could say this is exactly what we need to do and how we need to do it. But this is kind of, as we've experienced in the last couple of years, a little bit of unprecedented territory of what
Yeah.
it's going to look like.
Yeah. Yeah. Okay. Well, I think you brought up a couple really important points. That it is important to know how you're vaccinating, what you're using to vaccinate, what authority you have, and what that's following. Because if it is following CDC, then that means, you have to think about how this shared clinical decision making fits into your authority to vaccinate. But it may or may not, depending on your state and your standing order or collaborative practice agreement. So you sort of have to know your specifics there. And also, the insurance coverage is not something we expect to be infected, but sort of just need to be aware of potential considerations maybe down the road there. But um, I think that's helpful perspective to understand why. the shared clinical decision-making concept, we need to be aware of it, despite the differences in those sort of groups of vaccine recommendations. But we are often having discussions with patients around vaccinations in general and sort of weighing, especially
Mhm.
in, with a lot of questions about vaccines coming up recently in general, we are often having these discussions anyway. And so maybe we can be thinking about how this fits into practice and what we're already doing and how we can just sort of optimize what we're already doing to ensure that we are doing this shared clinical decision making. So maybe we can walk through a little bit more of that specifics around the process and what that conversation looks like with patients. Is there sort of a structure we can follow or like a step-by-step process that we can be thinking about? Well, what does this look like when you're actually talking with a patient?
Yeah. And so I think it's going to vary a little bit, and especially when we have vaccines that it'll be an interesting because you have vaccines that haven't had the shared clinical decision making attached to them in the past, and
Mhm.
then now all of a sudden we are, right? And so
Mhm.
how does that work?
Mhm.
Um, I think one way to kind of be aware is that, historically, I'm going to just go to influenza because I think it's probably the most common, obviously, that, we vaccinate with in pharmacies and for that
Mhm.
age group. And in the past, a patient would come in and you would say, or caregiver would come in for a pediatric patient and you would say, oh, um, Rachel hasn't received their vaccine yet today. So
Mhm.
it's time for them to get their influenza vaccine. Would you like
Mhm.
to get that today? Kind of that presumptive approach that they're going to be
Mhm.
vaccinating. If
Mhm.
you're really following shared clinical decision making, if you're actually following the process, that's not what we would do. And so, there again, if you're following the AAP schedule, then you would say time for your vaccine. But if you're following more of that shared clinical decision making recommendation, there needs to be an open dialogue and conversation, and it does take a little bit more time. I would say that you can still be the expert in that conversation
Sure.
when the patient is there, right? So you can
Mhm.
still say, based off of I'd like to have a conversation, and we should have a conversation today about, Rachel getting the influenza vaccine based off of, their risk and whatever, I think that they should get that.
Mhm.
And you can ask them, kind of what their thoughts are and risks are. Now, again, without evidence to recommendation, it's really hard to have a true shared clinical decision making because I don't know what would put that child, I'm saying Rachel, obviously you're not a child, but
Mhm.
I don't
Mhm.
know what
Mhm.
would not put them at risk for
Right.
influenza. I don't have
Mhm.
evidence to tell me like what wouldn't, but you can still have that conversation with them and be that expert and say, you based off of the evidence that you're aware of, they should get you think they should get the vaccination. And is there any reasons that, they feel like they shouldn't get the vaccine?
Mhm.
And
Mhm.
they can share that expertise with you, or do you feel like
Mhm.
there's any reasons why they wouldn't be at risk? And you can kind of share that conversation back and forth, and then go ahead and come to a conclusion together on what should be done. Um, there's a model that's been used in the literature for a really long time. It's been around now for almost a decade and has been kind of cited the most of all the models, and it's called the three talk model. And it's pretty easy to follow. That's why I like it. It's a three talk model, but it's having a conversation of a patient with team talk, meaning like both parties come together as a team and they talk about the decision that needs to be made and about their own experiences and goals.
Okay.
Then you have option talk, which is okay, now that I have that information, what are your options? And then decision talk and having that go through. So if you're following that model with maybe something like a pediatric influenza vaccination, coming together as a team and having that conversation with the parent or caregiver that it's that time of year and they should decide,
Mhm.
you together should decide whether or not that child's going to get vaccinated. That would be like a decision talk, and identifying if there's any reasons that they feel like they shouldn't get vaccinated, and you sharing, potentially what it is that they should do, and their options are either vaccinated or not vaccinated, and then decision coming together whether or not they should be vaccinated or not. So if you're following like a true shared clinical decision making, that's kind of that process.
Okay. So I it's helpful to hear sort of that model. Team talk, decision talk. What
Or
was
team talk, option talk, and then decision talk. Yeah.
Okay, team talk, option talk, decision talk. Right, that makes sense.
Mhm.
Okay, so working through that as sort of your framework to follow, that's helpful. And you mentioned that that might take a little bit more time. So any sort of best practices for having that conversation efficiently, or
Yeah.
how to fit that into workflow?
Yeah. So I definitely think that having, personally speaking, I think one of the challenges that we've had with shared decision making is the differences in, EHRs and software systems as to how they're flagging shared decision making
Mm,
recommendations. So I
I
personally,
agree.
I hope that we continue to flag these pediatric patients as people that we should be talking to with
Hmm.
for vaccination or their caregivers.
Okay.
Um, but then I think workflow is, having, this isn't something where, again, you have maybe the pharmacy technician at the checkout and saying, oh, it looks like we have a note here that you're due for your influenza vaccine. We can get that for you right now today. It's not that easy. It is more of a, hey, oh, we have a note here that the pharmacist wants to talk to you about influenza vaccine. Can I have them come over and talk with you about it? One of the challenges with that is that it does take more time.
Hmm.
It's been documented in the literature, at least for when physicians were surveyed as to shared clinical decision making versus non, 90% said it took more time, and which we can see, right? I mean, we just gave two
Hmm.
examples, and
Sure.
one's going to
Yeah.
take more
Yeah.
time. It's not
Hmm.
but at the same time, it doesn't have to take, 20 minutes. It can be a few
Hmm.
minutes.
Hmm.
I think one of the challenges, again, that we have as pharmacists, and even providers sometimes have this challenge, is that you don't get paid for that time always.
Hmm.
So as a pharmacist, we don't get paid typically for that time. Some states, and North Dakota is one of these states, that we are recognized as providers for state Medicaid. And so under our state Medicaid, a pharmacist can get paid for their conversation for vaccination for a pediatric patient. It has to be under 18.
Okay.
And then we can get paid for our time to have
Okay.
a conversation with them. Interestingly enough, though, is that if they don't get the vaccine, then we can't actually bill for it. We can only bill if they don't take the vaccine. So it's an
Interesting.
interesting, it's an
Uh,
illustration. Every state's different. I mean, just because
yeah.
it's that
Yeah.
North Dakota, I don't want anyone to think that it's like that
Yeah.
in their state.
Yeah.
And also, not every state where pharmacists can provide medical billing under
Sure.
Medicaid. So you'll want to look at that. But there is an opportunity for
Yeah.
pharmacists to actually get paid for having that conversation in
Yeah.
some states.
I think
Hmm.
that's super important to call out because, as you said, if there is additional time being taken to have these conversations and just being aware of what's available in your state in terms of billing and what you might be able to be reimbursed for that extra time, that is super important because I do know there are some other states that have a similar model where you can bill Medicaid for these conversations, and some do allow you to bill even if the patient refuses vaccination. So it's very variable and just another important reason why, advocacy is important and making sure we're pushing for the value of pharmacists and having these conversations, but also just being familiar with the fact that this is an option. It's something to look into, especially if you're concerned about the time aspect of things. Um, so in terms of sort of thinking about how to have these conversations and getting it sort of, I guess I'm thinking about the patients who maybe haven't heard that anything has changed or not really concerned about the fact that the recommendations from CDC have changed for pediatrics. They come in for their flu shot for their child. It's not a mandated. I mean, like again, it depends on what your state, what you're following, I guess. But
Right.
what if the patient agrees up front? How would that situation look like if they sort of come in and ask for the vaccine proactively? Does that change how you would have that conversation?
Um, yeah, I mean, I'll be honest, if you're really following a shared decision-making model, yeah,
Yeah,
it does.
yeah.
When the RSV vaccine, I'll give an example with RSV vaccine because there was evidence at that time for shared decision-making. I'd have patients who would hear about the RSV vaccine and they would come and say, I want the RSV vaccine.
Hmm.
And I would recognize that and know that that's their goal, but I would also just
Sure.
provide some information based off
Sure.
of the evidence to recommendation again, but I would provide
Okay.
some information as why it is that we aren't doing a blanket recommendation for everybody.
Yeah.
And I would talk
Okay.
about their age and their risk factors. And the conversation would have been very different for somebody who was, maybe 67, 68 years old or something like that, and didn't have any health conditions versus somebody who was 75 years old or 74 years old and had, diabetes and emphysema. So I think
Mhm.
uh, sharing that information is important. But yeah, I'll be honest, like I think that's why people are getting a little up in arms about this because what we don't want to do, and we've never done, and especially as pharmacists, is be like, oh well, patient care doesn't really matter. Like that doesn't matter, and we've never done that. We've always been so great and I would argue the best at patient care. And
Mhm.
so if you're really actually following shared decision making, then um, you should have a little bit more of a conversation. But at the same time, if someone comes in with a child and says, "Oh, I'd like to get my child vaccinated against influenza," and you can say, "Okay, that sounds good. I would, the evidence does show that everyone, blah blah blah, should be vaccinated." And do you have any thoughts or concerns or questions about the vaccine, and
Sure.
kind of go from there. But
Yep.
it's a gray area because really, shared decision making isn't informed consent. And so it's just if you're really
Right.
following the model the way it's was intended to originally as a recommendation from the CDC,
Right.
there should be a little bit more of a conversation about that. But um, I would say that there's also a reason why the AAP that has their own
Sure.
schedule, the
Yeah.
American Pharmacists Association has endorsed that schedule too.
Right.
So
Right.
I
Great
would say it
perspective.
would go down to as to your state law and legality of which schedule you have to follow, and then as well as if there's any documentation you need to provide
Sure.
that decision
Okay.
making has been had or a conversation's been had. Hmm.
Yep. Okay. Really important point there. Um, okay. That's great perspective. And like I say, I do think we are often having these conversations with patients anyway as pharmacists, and especially for patients who may have been more hesitant for whatever reason in the past. These are sort of routine conversations that are going on around vaccines every day. It's just sort of changing the scope of when you might be thinking about needing to have that proactively compared to what it might have been before.
Hmm.
But I do think all of this helps to illustrate the critical role of pharmacists in working with patients and providing vaccinations, in preventing disease and supporting, protective herd immunity, all of these sorts of things. Maybe you can just speak a little bit, about the benefits of pharmacists and what we can do, how we are empowered to take on a particular role here, given these changes. I think maybe we can be a bit
Yeah.
empowering, with some of this. Um,
Great. Well, I will say a few things. There's a few things that have not changed, right? We're still the most accessible healthcare provider. We're
mhm.
still arguably the most trusted health professional in the country. And we are still heavily relied upon by our patients to provide vaccines.
Mhm.
So, and other things that not change is that, a, a strong recommendation. So you being the expert is
Right,
one of the leading things that can lead to vaccination. And
right.
the evidence behind these vaccines, unless shown otherwise, hasn't changed. So before we go to, oh my gosh, this new change and Chicken Little, the sky is falling, take a deep breath and realize this has not changed. This is the same. And
Yeah.
and so it's a little bump in the road of maybe clarifying of how you need to document something, or how you need to follow legally the protocol in your state if there's anything your board of pharmacy would require you to do. But other than
Mhm.
that, I would say that probably your approach isn't really going to change. And another thing too is, and I can't stress this enough, is don't stop carrying these vaccines. We
Yes.
cannot decrease our access to care because of this. The
Yes.
worst thing that can happen is, especially when we're relied upon so heavily by our patients, is to say, oh, well, what, this is just seems like a lot of work. I'm not going to not going to do
Hmm.
this right now, or, they can go get it somewhere else, or please do not do that because our patients are relying on you. And as we can see what, lack of vaccination is doing in our country, like
Right,
just look at measles right now. I
right.
mean, it is going to be critical that we still are providing these life-saving preventative measures to our patients. And so I would just say focus on what really hasn't changed. And
Yeah.
most of it hasn't. So just to be aware of kind of the nuances with these schedule recommendations.
Elizabeth, I'm so glad you gave that bottom line because I think that just emphasizes again the important role of pharmacists in providing that access to care, preventing disease, improving patient outcomes, making sure that patients have access to life-saving preventive measures. That's critical and just such an important role that we play. So I just think you summarized that really well. And think about what hasn't changed. I love that because the evidence hasn't changed. The strength of our recommendations doesn't need to change. It's just a matter of how we need to maybe communicate that with the patient if, depending on the situation. And you actually mentioned states too. The other thing I just thought of is that some states are also changing their vaccine recommendations or standing orders or various things to comply with maybe other organizations as well. So it's also a state specific thing from that
Mhm.
perspective in terms of what protocols might follow. So that's another consideration to be aware of where the state itself may follow certain protocol or sort of certain recommendations versus others. So yeah, really important point there. And I also really appreciate they mentioned making sure to continue to sort of operate business as usual in terms of making sure you have vaccine on hand. We don't want to be having a shortage, especially in light of all of these changes we're seeing with increased infectious diseases sort of popping up across the country. So super important point there. And I do want to tie that into the concept of rural areas because I know pharmacies are often maybe one of the very few providers in a rural area. And so we can play a critical role there too, and being that continued source of preventive care for many patients. I don't know if that's something that is you have experience with personally, or if you can speak to that at all in terms of the role pharmacists play in that rural setting too, specifically.
Yeah, well, I'm from North Dakota, so I have a lot of I can tell you I have a lot of experience and I can speak to
Yeah.
that very well. And so yeah, and in North Dakota, we also have a state law that requires the pharmacist to be, the owner of a pharmacy needs to be a pharmacist, at least 51% ownership of the stock. And so the very large majority of our pharmacies in the state are independent pharmacies, or at least pharmacy owned pharmacies.
Yeah.
Or pharmacist owned pharmacies. So um, I will say that with that said, that our pharmacies are such a critical access. We've done some mapping in some of our states, and the pharmacist is literally the only healthcare provider in a county. So if
Wow.
you do not offer the vaccine, this patient cannot get that vaccine anywhere within like probably a reasonable driving distance because we have a lot of land area in North Dakota
Hmm. Hmm.
and our counties are quite large. So, to be thinking of that, of access to care,
Hmm.
but also even in our our urban areas, it's sometimes even
Yeah.
the urban areas, the pharmacists are definitely the most accessible because of
Yeah.
transportation or social determinants of health or other measures. And so that doesn't, I would say that access and the importance of, knowing the nuances right now with the vaccine recommendations and making sure you're stocking those vaccines, making sure you're having these conversations with the patients. There's can still definitely flag anyone that is under that because they should.
Mhm.
That's one of the problems with social or shared clinical decision making in general is that sometimes patients who really need it historically haven't been identified because they've just kind of been forgotten about. And so please make sure that's not happening either, making sure that we're still flagging all these patients and ensuring that we're having these conversations with them and to see to give them our ideas and our recommendation and our expert, which you do in shared decision making of them getting vaccinated.
Absolutely. Yeah, great emphasis there. Um, I do want to just sort of tie in the concept of health coaching here because I think that's another area that pharmacists, and you mentioned motivational interviewing before too, but just the idea of pharmacists supporting patients in overall health and well-being. And Elizabeth, I know you have some expertise in this area too, health coaching specifically. So maybe you can sort of tie together, like how do those concepts compare, shared clinical decision making and health coaching? How do they work together, if at all?
Yeah. They're really similar in a lot of areas. In a health coaching environment, you're still the expert, just like shared decision making. You're the expert as a healthcare professional in this. And then the patient is the expert in their lives, and trying to gather information from that patient is very important in both models.
Hmm.
Also leading with empathy and leading with, understanding and in trying to, gather that information and having ongoing conversations with our patients in both models is really applicable. So I think that, and even, social shared clinical decision making is very different also than motivational interviewing. There's still pieces of all of those that can be played into each of these of having asking open-ended questions, trying to
Hmm.
gain
Hmm.
understanding,
Hmm.
trying to still be the expert of health and the patient of, what about the guidelines and the evidence, and providing that information, and also asking the patient to provide information.
Hmm.
Both of those, in health coaching, the skills that you use in health coaching are 100% applied in shared decision making.
So there's a lot of overlap, but also differences too.
Yeah, slight differences in the fact of a lot of times with health coaching, you're kind of trying to get the patient to move the needle to like where you
Okay.
want them to be.
Hmm.
And
Hmm.
again, in shared decision making, historically speaking, of how it was laid out, y- there there is a little bit of a goal, but the goal is not I'm going to get them to exercise 5 times a day, or I'm going to get them to
Sure.
do this. I'm going to get
Hmm.
them to, um, get this vaccine. That's not what true shared decision making is. It's gathering information from both sides and then coming to a conclusion together. So there is a little slight differences, but
Sure.
still a lot of the same principles and
Hmm.
your expertise and what you need to talk about are very similar.
Hmm. Okay. Okay, that's great clarification, and all of this is about strengthening these relationships with patients. I do want to mention that CEimpact does have a health coaching course on our website. It's called "Get Off the Sidelines: How to Engage in Pharmacist-Led Health Coaching," and it's I know Elizabeth, I think you were involved in the development of that course as well, and so
Yeah.
just helping to understand sort of a range of topics, including behavior change and motivational interviewing, and some of these communication techniques, like you mentioned, open-ended questions as an example, just to have a sort of broad-based understanding of how health coaching can be applied in practice, and also you can bill for these services too potentially. So just a good opportunity to get those tools and keep making that positive impact on patient care. So, Elizabeth, I know we're out of time. I do want to wrap up. It is our Game Changers podcast. And so we always end the conversation with what do you think is the game changer for our listeners to walk away with? So, what's the most important point you think that we need to take away from these changes in this update?
Yeah. I would just say the game changer is understanding that, a lot hasn't changed, so I'm just gonna
Yeah,
highlight that. And,
yeah.
so although it's a game changer, I think that the game changer is that so much has not changed. The evidence hasn't changed. The pharmacist's ability and expectation to engage in shared decision making and making those recommendations, and the ability and necessity of the pharmacist to provide vaccination hasn't changed at all. And so I think the game changer would be even just the highlighting of that,
Mhm.
in light of these new recommendations coming from the CDC, to highlight that our role and what hasn't changed.
I love that, sort of flipping that concept on its head. It seems
Not ever have I flipped it, but I'm going to kind of, I feel like I've given a couple of podcasts before, and I can always think of the game changer, but this I am going to flip it back as to a little bit, as to a lot has not changed.
I
Yeah.
think it's great. And going back to your comment about Chicken Little, like let's not, the sky is not falling. Let's think
Mhm.
about what hasn't changed and how we just can continue to provide these vaccines and provide improve access to care for our patients. And that the evidence hasn't changed either. So that's just a really great take-home message. So thank you so much. Really appreciate your time, Elizabeth, and really thankful for your expertise in this area. You had a lot of great practical examples and lots of important considerations for us to be thinking about. So really appreciate it.
Yeah, absolutely. Thanks for having me. It's always a pleasure.
Excellent. Well, listeners, we talked about a lot of great practical tips today, and these will also be summarized in the practice resource that goes along with this podcast on the CEimpact website. So I just mentioned that, so you can take a peek at that, as well as the podcast, sort of side by side there. And be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.